The next speaker, Dr. Karthika Chandran.
Good afternoon, everyone. I'm Dr. Karthika. I'm going to talk today about a review of use of retropupillary fixated iris glow IOL in pediatric population. I have no financial disclosures. Moving forward, whenever I mention iris glow implantation, I mean retropupillary fixation. So in pediatric cataract, the norm is to do a lens aspiration and do in the bag IOL fixation with or without PCC AV. But in some special cases, for example, like a traumatic cataract where there is an absent bag or absent sulcus, or in cases like Marfan's where there is progressive weakening of zonules, it is not possible to do a in the bag IOL implantation. In such cases, we have few other alternatives. And iris glow IOL implantation, especially retropupillary fixation, is a relatively safe, affordable, and relatively easy to perform procedure which can be used. There are many studies on iris glow IOL implantation in pediatric population, but most of these studies have some lacunae, like small sample. They either have small sample size or a limited follow-up, or they might have included older age group. And most of these studies have assessed mainly visual outcome and complications. So in our study, we have assessed refractive status and prediction error in retropupillary fixated IOL in pediatric age groups, along with indication, visual outcomes, and complications. This is a retrospective study done from 2021 to 24. We have included all cases of retropupillary fixated iris glow IOL in pediatric age group, except those with incomplete data and incomplete follow-up. And we have used Excel lens with an A constant of 117. It is a non-volted design, and hence we have done PI in all cases, and the power of IOL implanted is calculated by undercorrecting one diopter from a PCIOL power with A constant 118. Sorry, the PPT which is uploaded is different and the pictures have not come. Please excuse me for this. And these are the data collected. Of this, we have mainly measured 3 outcome measures: prediction error, visual outcome, and complications. Prediction error is calculated as observed refraction minus target refraction, where observed refraction is the spherical equivalent at 1 month after suture removal. In cases where the child is less than 7 years, we have done an undercorrection of 7 minus age, and in such cases that will serve as the target refraction. The visual outcome is a BCVA at final follow-up. We have assessed 40 eyes of 25 patients with age ranging from 4 to 18 years and follow-up ranging from 3 to 30 months. We have included cases with comorbidities. Our most common indications were idiopathic ectopia lentis and trauma, accounting to 28% each. Other indications were Marfan's, microspherophakia, and surgical aphakia. The mean prediction error was 1.231 with 22 overcorrections and 16 undercorrections, and there were 32.5% cases who had prediction error of more than 1 diopter. It is to be noted that all patients with corneal scar had a prediction error of more than 1 diopter. Now, 70% of our patients had visual acuity better than 618 at final follow-up. Those which had vision less than 618 had causes which are enumerated here. The most common intraoperative complication was traumatic enclavation, and post-op complications included raised intraocular pressure, disenclavement, pupil ovalization, AC reaction, etc. There were 3 cases of IOL disenclavement. None of them had any preceding history of trauma, but all of them had history of traumatic enclavement during surgery. And the most common post-op complication was raised IOP. There were 9 cases, of which 1 was a steroid responder, and the other 8 patients had transient raise of IOP, which was noted from 1 week to 2 months after surgery. All were managed medically, and it is to be noted that all cases of traumatic enclavement again had raised IOP post-operatively. This is a study by Shoaib et al. In this study, they have assessed the prediction error in iris glow implantation, and they have similar results to us, only that their prediction error is much less, maybe because they had not included trauma cases. And haptic disenclavation was 20% for them as opposed to 7.5% for us. So, though our study has large sample size and we have assessed prediction error, since it is a retrospective design, we might have missed small findings like iris atrophy, pupil ovalization. Also, we wanted to assess how much the lenticular astigmatism by the IOL is contributing to the prediction error, but we couldn't do that because it is a retrospective design. So to conclude, Iris Glow is a safe and effective solution for pediatric cases with insufficient capsular support. And the most common complication was transient rise of intraocular pressure. Disenclavement can be seen in 7.5%. In all cases which have traumatic enclavement during surgery, we should keep them on a lookout for raised intraocular pressure and disenclavement postoperatively. Thank you.